those of you who don't know me, I'm Marcia Philbin. I'm the Chief Executive of the Faculty of Pharmaceutical Medicine, and I'm delighted that you're joining us for this special webinar. Looking at the time, I think we will start now, and I will turn over now to Professor Mark Turner, who will chair this session. Thank you, Mark.
Thanks, Marcia. It's a great pleasure as an honorary fellow of the Faculty of Pharmaceutical Medicine to moderate this session. We've got three great speakers, and we've asked them each to speak for about 5 minutes on their experience of preparing and managing public health emergencies with research, with medicines and devices for children. So each of them is going to talk for 5 minutes, and then we're going to have an open floor. We'd welcome comments from the floor, people comparing experiences and reacting to the reflections from the panelists. At all times, please use the chat facility. The chat bubble at the bottom of the screen opens up a window. You can chat to everybody. You can chat to a person of your choice. So sometimes we can mingle like this as if we were in a real place. Please comment, but please ask questions, because we'll then use the questions to stimulate the discussion during the largest part of the call after each of the panelists has spoken. I'll remind you that the session is recorded, so if you don't want to be recorded, I'm afraid you'll have to leave, but please don't leave. And at the end of the session at 5 o'clock UK time, there'll be another session that runs on sort of an open tea garden where we can continue the discussion, building on the themes of the call or adding in new themes as time goes by. So without any further ado, let's move on to our first speaker, and let's start with Professor Marianne Kruger from South Africa. Marianne, the floor is yours.
Thank you very much. Yeah, as already said, as a pediatric oncologist, but as a pediatrician, I think one of the major roles for pediatricians are to advocate for their child patients at all times. And we know that we have a problem in that we don't always have access to new and novel medicines for quite a number of diseases. So clinical trials and research is really essential in pediatric healthcare. And at the moment, of course, with COVID-19 in South Africa, we have followed the principle spelled out by the WHO to stop all clinical trials that may impact negatively on the emergency healthcare work needed for the COVID pandemic. And that has had major issues. Now, just the context of South Africa, we upper middle income country. We have a population of close to 59 million, 30% of them are children. And our major burden of disease is, of course, HIV/AIDS and tuberculosis. And I mean, we have roughly about 7.6 million persons living with HIV/AIDS in South Africa. So it is crucial for us to continue our clinical trials. The typical of clinical trials that are currently being conducted in my department are for example, the TB-CHAMP trial, which is for multi-drug resistant tuberculosis. And at the moment, we can only keep those patients that have been enrolled prior to the COVID pandemic in the study, but we cannot recruit more. And you all know multi-drug resistant tuberculosis is a major issue for us. So coming to the question, how do we approach it in a pandemic? I really think we need to advocate for those children to continue the clinical trials that are there to improve their healthcare. We've just had a meeting with all the heads of department in South Africa to look at how the impact has been of COVID on children. And we know that it's a mild to moderate infection. In actual fact, it's very mild in South Africa, not very high incidence. And so we are actually neglecting children's healthcare. One of the other major issues that, of course, has happened is that we've had little access to medicines. I mean, we are importing most of our essential pharmaceutical requirements from China, and then we produce our own drugs. And so with first China having the COVID pandemic and they couldn't export, and then we have a severe lockdown where we couldn't import, we are running into the shortages of medicine. So that has had some major impact on our healthcare. We are currently very concerned about the fact also that children did not get the vaccines. And so we need to look at ways of addressing this because most of the clinics were closed. We have, prior to this pandemic, already experienced major stockouts of medicines to the extent that an NGO was started, which is called Stockouts Project, which now addresses, and you can report where they stock out so that they can then pressurize policymakers and government to make sure that we have the medicines. And the important medicines, again, that has been in the past been out of stock are, of course, tuberculosis medications, vaccinations, and antiretroviral therapy. And this is crucial that we do have this. So in a nutshell, the pandemic has not been very friendly to South African children. Another added factor to this is that most of our children are not going to school at the moment because schools are not open yet. And unfortunately, close to 4 million children are actually getting a daily meal in South African schools. So you can just realize the impact of it on our system. But the major concern is that we need to continue our essential clinical trials in HIV/AIDS, better formulations of medicines, as well as tuberculosis. Thank you, Mark. That's in a nutshell what I wanted to start with.
Thank you very much. And I think that gives a really good setting, reflecting one important setting, but also brings up many issues that other people need to consider in practice and also in research. So maybe we can hop continents now to Brazil, to South America, and Sydney. Maybe you could make some comments. Oh, but we can't hear you.
Thanks for the invitation. I'll try to make an overview of where we are. And as everybody knows, Brazil is a continental country. So I can say about parts of the country because it's moving, everything is moving quite, and we start a little bit later. So in certain points, in certain areas like São Paulo, it's much more well developed than the rest of the country. We are a little bit more prepared. And we are located in the eastern part of the city of São Paulo, which is the state of São Paulo, where we cover the hospital about 5 to 6 million people. So we have a good number to say and to reflect what's going on. And it's the poor area of the city, eastern part. I'm pediatric oncology, department of pediatric oncology there at Santa Marcelina, where is based in that area. We have a support of NGO, so we were prepared to give the essentials necessary to give a good quality of treatment and approach for those children, so that when the pandemic
we seem to have lost Sydney. Sydney, can you hear us? You've frozen. Okay, maybe we can pause a little bit, but Barbara, I wonder if you'd be ready to join, or should we wait? Oh, Sydney, are you back?
I'm back, sorry, I don't know what happened.
So you froze when you said that you're getting ready for the pandemic.
Well, so I was very afraid about the pandemic when they arrived, because those people were the people that live in the slums where we attend the parents and the children. So very difficult. But that's why we always give transportation. We always give basic food for them to keep the treatment since many, many years. So we had to add some points for them with the pandemic. But we were able to keep giving treatment and keep all schedules necessary. Even in the hospital across the street, there was 1,000 of patients with a COVID positive. As we are out, and we were able to be out of that for the last 4 months, since March, when the pandemic in São Paulo and Brazil started, we have only 7 patients with COVID positive. So that was a very good impact for us, because we were trying to give them, all the necessary needs. With this, we were able to keep the treatment. The impact for us was the number of new patients, because of the government closed the primary care for pediatric, for everything, everywhere in the city. What happens in the second month? the number of new cases in the department decreased for 70%. So now the numbers are growing up again. So probably we have a much more late diagnosis in the future because people are not going to the doctors the last. But that's not only, I don't know, everybody knows that we have the private system and the public system. 8% of the population in Brazil go to the public service and only 15 to 20 go to the private. Doesn't matter, nobody went to the doctors, and so the numbers of new cases, wherever you go, decrease. Now it's going up. So, and if we were not able to give this everything we were given before, it would be a mess for us to face this pandemic the last 4 months. So we were ready for, not for the pandemic, but we are ready for all the needs they already have for that population that allow us to be able to keep doing what we are doing in the way we are doing, and not having such a big number of patients. And we have no death, only one death related to the virus, because the patient came from the other hospital in a very bad condition, already positive and with disseminated disease in the abdomen. And that was for the late diagnosis elsewhere. All the other 6 patients, they are alive, and we were able to do quite nicely with them.
Okay, well, thank you very much. And moving on to Barbara, so another continent. So Barbara, your comments, please.
Sure. So thank you so much for inviting me. I am in Boston, and we've had the unfortunate problem of being one of the first waves of the pandemic that hit the United States after the China, Italy, and now, of course, we were the early hotspot, and now, fortunately, less so, but the US is nowhere near controlling the incidence of the virus and is doing a really challenging job. Let me bring it back for a second to say that I think the most important part of what we've learned now is that we should not compromise scientific integrity or the ethical foundations of research in approaching what we do and how we respond. And I fully support the comments of my other commentators. I think initially we really didn't appreciate the impact of this pandemic on children, and thought that we were not going to see the kind of incidence that we might have anticipated. It is true that we have not seen the severity of disease, but that is not to say that we're not seeing a significant incidence of infection, that kids are turning out to be a serious and significant reservoir for the virus. They live at home with people that do get sick from it. And I think that we should not underestimate the social and behavioral impact of this virus on both their well-being and their health. We have now seen, after several reports from the UK, this hyperinflammatory manifestations of the disease in pediatrics. And in response to that, we've seen a steady increase in the number of trials to try to understand both the incidence, the social and behavioral impact, and now the treatment in children. Unfortunately, many of those trials, at least in the US, have been single site, often single arm, underpowered, and I fear not particularly informative at the end of the day. But it is certainly, as a society, exposed significant problems, both in terms of how we approach clinical trials, that they are not coordinated. There is a lack of leadership. We don't even have sort of common data standards, data collection tools, so that we could make the data interoperable even post hoc. And it's quite unfortunate we're there. I also think that these kinds of conferences are very useful for responding to pandemics, because there is a systematic lack of communication, and we should all be learning from each other, not just living in our isolated, sort of sentiments. What we have seen is that as schools reopening in other countries, like in Israel, are seeing a massive increase in the number of cases. And of course, we don't know what will happen here, but I'm not hopeful given our current leadership. It has also exposed significant structural and systematic problems in our social fabric in the U.S. Kids live at home where the recommendations for positivity are social isolation. They live in one room with 12 people, and they cannot socially isolate. Their parents are often essential workers. Even if they're not the physicians, they are essential workers taking public transportation. We don't even capture this kind of information. So we've seen a real sort of increase in incidence and severity among underserved and minority populations, at least in the US, and for reasons that we're not sure, whether that's comorbidity, social determinants of health, or other social factors. So I should also confirm what Mariana said. We're seeing a huge disruption in regular medical care, as well as ongoing clinical trials. We too have had to shut down almost all the clinical trials as the virus has swept through the States. That includes pediatric oncology trials, and we've had the same situation. We've kept only trials that are therapeutic going, and those that do not require any in-person visits. We've seen huge changes in the way that we conduct trials, moving to virtual home delivery of investigational products and other things. But we have seen a disruption in the rate of vaccine delivery of normal vaccines for children. And I fear that we'll see an increase in, diseases of childhood. As we think about the pharmaceutical response, which was one of the questions asked of us, I think that one thing that we need to be sure of is that at every stage, we advocate for children, as Mariana said, we prepare for the impact on children, as Dr. Eichelman said, and that we continue to push for formulations and expedients and clinical trials that are appropriate for children. We don't know at the beginning of these pandemics what will happen and what the impacts will be, and we should always keep that front of mind. In terms of the social and behavioral studies, there are many observational studies, and we'll learn. The controls are very hard to do, and therefore interpreting this kind of data will, I think, be challenging. Mm-hmm. Let me pause there, say there's lots more we could talk about. One of the challenges, we're trying to coordinate a group in Texas, for instance, that's seeing this wave of infections now, to try and coordinate the response and use of convalescent plasma in children. But actually, we only have, in many sites, 1 or 2 children. So it's hard to get people to really commit the resources to do good clinical trials at a time when they're so spread out. So I think we do need global cooperation and harmonization of approaches in a way that we haven't really attended to before, but I think is endemic to how we should be approaching pediatric diseases going forward. Thank you.
Great, thank you very much. Now, we're looking forward to the questions, and maybe we could start with the question that's on the screen at the moment from Malcolm. In any future pandemic, who should coordinate clinical trials to avoid splintering into underpowered, non-comparative studies? Should that be international societies or the World Health Organization? So maybe we can take a random go through our panelists, and maybe Sydney could comment on that question first.
Well, we didn't have that much impact. Most of our studies keep going with monitoring through virtual. So as I said, we didn't have that big impact at this point for our, and again, it's the trials in our department are very somehow under control. It's not pediatric oncology. Usually we can handle a little bit better because the numbers are much less. But I really think that we should have a very good control of that, because I had some impacts in some studies that was supposed to start, and because of the pandemic, everything became the priority. And I think we should also discuss that because we are now in my field saying that cancer doesn't wait. So as Dr. Bierer said and Dr. Kruger, we know that patients need to have and keep going with the treatment, and we don't know how long the impact of that's going to be. Even we're going down in some points. In Brazil, we have a lot of time to go. So we really need to have a better coordination and discussion about, because many agencies just said we are closed for new studies, we are closed to keep going, we are closed because of the pandemic, as everything else doesn't matter. So I think that we have to have a very political, and who is going to coordinate it? I don't have the right answer probably, but somebody with the strength to have some political issues, not to say, well, let's forget everything and just the pandemic or the COVID is the all important. As I said, the cancer doesn't wait, and all the disease as well. We have to have a better coordination. Maybe the international society, together with WHO and together with some strong people that really can fight with that.
Great.
But
thank
not
you.
The best answer.
Thank you very much. Marianne?
Yes, thank you very much. I think it's a very important question, and I think I want to just take pediatric oncology as an example. If it wasn't for the international collaborative research that has been taking place since the early 1950s and expanding all the time, I don't think we would have been with pediatric oncology where we are. So I think in a sense it is back to the societies, and I also want to link it to the HIV/AIDS society, because in a sense those are usually multi-center international studies. It has been a huge epidemic, has had major impact in South Africa and in the rest of Africa, and through that collaboration I think the colleagues actually know each other. And so I think it is really that the society should do it, because WHO, in a sense, is there to push policymakers to make sure that there's healthcare for all and to push for universal immunization programs. So I'm not convinced that it's actually their duty to also make sure that the necessary research are taking place. They should rather support us in getting policymakers to support the research. But I think it's up to the societies to come together and say, listen, this is what we think, this is what's happening. My other role in our institution and in South Africa is as an ethicist, specifically research ethics, and so I'm very involved with most of that. And if we look what happened in COVID-19 with the adults, it's numerous studies that are coming in that we have to review, where we've developed a rapid review system, which we can talk about, because that's one of the important aspects, I think. But through that, you can see that adult medicine has really gone and contacted each other. So it's universal trials. There is, of course, the one trial that's coming from WHO, but the others have come from groups that already worked together previously on infectious diseases coming together. And I think specifically for pediatrics and pediatric infectious diseases, the HIV/AIDS community has been working together a long, long time. And so in actual fact, you should rather come and work together so that we make sure that when we do undertake clinical trials, there's good scientific value in the study, there's scientific validity, it's a good design. We can't just do research for the sake of research. It's got to be well-powered and really good comparative studies to prove beyond doubt that we are improving care. That is in a nutshell. Thank you.
Thank you very much. Thank you. Barbara?
So I'm probably a little bit more pessimistic about the ability of global collaboration in the absence of having infrastructure to support it. I think that we need to, if we're trying to control the splintering, as was said, of clinical trials, we need real leadership. I think that needs to be thought about from two angles. One, new studies in repurposed drugs in children that are really controlled by pharma, and then those that are academic trials. And we've seen much greater trouble in splintering in academic trials that are not funded or controlled or sponsored by pharma, at least in the US. I think there are really a couple of models that we should think about. One is regulatory cooperation at a level that we haven't seen previously, so that new drugs are tested across the countries and continents with regulatory exchange of information and potential support of the study design and the data collection and common data standards, so that we can really use that going forward. I think that for academic trials, the clinical trial networks that are in place do not necessarily connect with one another at appropriate times. And at least in the US, the institutions don't inhibit single site trials and say, if this is going on elsewhere, you must collaborate rather than do your own. That has many reasons, underlying reasons, not the least of which is sort of academic prowess is based on publication and, you know, first and last authors and those kinds of rather prosaic interests at a time when we should be collaborating for scientific evidence. So I do think the funders play a role, and I think WHO could play a very powerful role, as well as certain places like, at least in the US, the NIH, Gates Foundation, and other major groups that are well respected and can move forward to think through a plan going forward. Now, there are many groups that are trying to do this now, and ICMRA, which is the regulatory sort of collaboration or cooperative council, has already tried to think about how they're going to do this. I think we should all support those kinds of initiatives.
Great, thank you very much. I think it's worth noting that the WHO is doing some driving work in this space as well. The pediatric community led by the WHO is talking about a number of protocols for observational studies, and the maternal and newborn health bit of the WHO is actually coordinating a joint study. So to Marianne's point, they do have the capability. It differs between different segments of WHO, but if we learn from Ebola, if we learn from this, then we can begin to project that so that all the societies and other groups are ready to work together.
Exactly.
And the ISTERIC study is an example of how that could work in future, and we need to be making those connections now for the next time, and taking all the points that Barbara and others have made. So,
but just can I add something?
Can I?
Yeah, please.
Just one point for countries like Brazil, where we are based to have a drug that's not given by the government or covered by the government. The clinical trial is an instrument to access. Mm-hmm. So that's a very important issue, because if you don't, even academic or pharma-related clinical trials, the two sides are not supporting that. So we have a lack of, I don't mean essential drugs, but drugs at this point could be accessed and could save some lives. So that's a big issue in the country. and that's not the priority here or in countries like with this kind of political and economical issues.
Yeah. And then you have the problem, even in clinical trials, of scarcity of medicines. So you've got an allocation problem.
Yeah.
Can I just link up with what Barbara said? I think, again, because of a pandemic, we've worked with HIV/AIDS for the last 20 years and intensively, and NIH has really been very crucial in clinical trials in the whole of Africa. One can also think in the East and all over. So in actual fact, I think that network of NIH is in existence and should be utilized for these kind of studies, because they are doing research in areas where the capacity is already built to do the good clinical trial, where the data managers are there. I'm sitting in a very research intensive department. We have 2 centers, one dedicated to HIV, one dedicated to tuberculosis, mostly funded by the NIH. And those staff are at the moment doing nothing because they are waiting for the pandemic to come to such a stage that we can recruit again. So in actual fact, if there was a joint study, the infrastructure is already there because it has been created by the NIH in a certain sense all over the place. And I think we must just build on the existing networks that are there already. Thank you.
Yeah, I couldn't agree more, but they haven't been deployed appropriately.
No.
Yeah. So I think we need to become more nimble in deploying infrastructure. But maybe we can turn back to some of the questions in the chat. Lisbeth Siderius has asked us, what do we know about the features of COVID in children? And how can we document features and diagnostic tests in a harmonized digital manner? That's quite a big question, but maybe we can just each signpost Lisbeth towards one resource that could help with that. Barbara?
So really good set of questions. So there is some observational studies now that are tracking natural history of COVID-19 in children, and that is in addition to obviously the hyperinflammatory syndrome that we all have become sensitive to. We do not know anything about the long-term impacts, for instance, on pulmonary function or other issues, and I trust that will start to be published. Whether there's going to be whether there are enough studies to look at subgroup analyses, both by socioeconomic class, race, ethnicity, age, burden of disease, etc. I don't know yet because I'm not involved in those studies. So I do think that if we look at what we could know in a digital world, I think that it's possible to develop a even ex post after collection, one could harmonize the data and learn a lot more. At least in many countries, there is some form of an electronic health record. And in the US, for instance, in the adult population, we're now taking the electronic health records of many large health systems, harmonizing it so that we have one data platform. It would be much easier to do that earlier and much easier if we had electronic platforms that were interoperable, but that's another conversation.
But yeah, as I said, the WHO are working on that for obstetrics, but not for pediatrics so far. Marianne, any comments on this?
Yes, I think at the moment we are too early in the pandemic to really answer all those questions. And I think these are actually the questions of the observational studies that are taking place in pediatrics. We are starting to see the syndrome for the first time now in the last 2 weeks. So we're really at the beginning stage and we are concerned. And of course, we are using a standard protocol across the country. We are going to share with each other our data in South Africa. But that will really be, only time will tell us. The interesting part is what are the features? Do they have other features? It's too early to say. We can only say that we've had about 8 at the moment here in our hospital. One of them with leukemia, one with chronic kidney disease, all have done well on what we've done, which is giving Solumedrol and Polygam, but it's too early to answer these questions. And so to answer Sidiri's, this is exactly the observation studies that's taking place at the moment in South Africa, trying to answer this particular set of questions. Thank you.
Thank you. Sydney?
Yeah, I agree entirely with Mariana said. It's too early. And we also have quite the same number, 7 we had. One that just I explained in the beginning, the other 6 were also observational is mandatory, but to add much more about that, I think it's still have some time to go. Let's keep going on that observation for sure.
Thank you very much. Moving through the questions, forgive me for my mispronunciation, but Tinashe has asked about vaccines. Does the panel feel qualified to answer that question?
Not very much, maybe. We are hoping for the vaccine, of course, but
anybody want to comment on that? Yeah. I think we'll have to accept our...
So I would just say, you know, one of the really interesting questions is, absent knowing anything specific about the vaccines in development, what would be the right path to get data on children? When should we begin these studies on children, and what are the risks to that? You know, do we need to know their health status before? And, you know, is this, if we're too careful, we could end up delaying any data collection at all for a very long time, as we've seen in other diseases. If we're too aggressive, then I think we put children at risk. So I think at first we need to see safety and neutralizing antibodies. None of us will know how long they're going to last. It was the Moderna vaccine was just reported yesterday on the phase 1 trials, so that looks good, but whether those antibodies are going to be long-lasting or prevent disease is unknown, of course. I think we should let this proceed in adults first, and then in normal children when we know that it's safe, before we do any children with comorbid disease. That's my personal feeling, and I don't think we should do challenge trials in children.
I want to add to that, if we look at the whole scenario, it is specifically the older you are, and if you have comorbid disease like diabetes or hypertension, you are more vulnerable. So in a sense, the question is rather to start off with those that are the most vulnerable because they need the vaccine most. And then if we look at that, very few children between the ages of 10 to 20 are getting the infection. It's mostly, if you do get it, under 10 and actually under 5, and then it's mild to moderate. And then again, it's from 50 years onwards in our South African data at the moment. So clearly we want to, and we have a huge population with hypertension, obesity and diabetes, and those are the risk factors. So when we do get a vaccine, we first need to test it in them and see if it works. And if there's then proof and we've doctored, we can vaccinate them, then I think one can start thinking about the children, because they're going to become adults and you'd like to then start protecting them. So there's a lot that needs to be, and again, I think one has to be very careful with a rushed affair of vaccines. We know that it takes years to develop very good vaccines. To date, we don't have an HIV vaccine. So I don't think COVID is really that different. So let's start with the most vulnerable for COVID, and those are the older age groups with comorbid disease.
Okay, thank you very much. Moving on to the international barriers. I think Heidrun's also mentioned this, but there is a common commentary between the EMA and FDA that I've posted a link to in the chat. So at the regulatory end, there's no more barriers than usual, although they have tried to work together. And maybe we can turn to the question from Tanya about our thoughts concerning hybrid and or virtual trials, telemedicine and so on, both for trials and for monitoring. Any thoughts?
So personally, I think that we should do that as aggressively as possible. I think that one positive aspect of this pandemic is the increased flexibility that we've seen in the conduct of clinical trials, and that what we now need to do is make sure that the data, has the same integrity, source documentation, and other things to make sure that we're confident of the data we're collecting. I also worry a bit, or more than a bit, about privacy and confidentiality in this setting. Another piece that we need to think through and develop. But you know, even at the advanced academic clinical centers, until this pandemic, we were talking about, or some were talking about, e-consents and not initiating e-consents. And you know, for all that we ask of our participants, the fact that we also ask them to travel to a center to have a, you know, what we call a well baby check is a challenge at best. So I think that that's all good news.
Comments?
Yeah,
Marianne?
I can just say that in actual fact, we have started the approach. I think adults are being recruited into studies for COVID, and then they're going to be followed up by a research team at home and all via telemedicine. And I think it's going to have a major impact on research in future. To date, I must say that we've already started prior to COVID, that researchers will go out with the medicines and the necessary checks to the communities, because transport to the central hospital where we're doing the trials are very expensive and it is time consuming. And now with COVID and the risk of getting infected while traveling on public transport, it has become. So we're starting, and I think that is going to be the future development for quite a lot of studies where you don't need more than checking that the patient is taking the medicine, that the patient is well, that there are no serious side effects or so on. So I think it's going to take off on a larger scale in South Africa. It will make a major cost saving for families, because they don't have to spend money on transport and be out of work. So I think it's really a future. Thank you.
Thank you very much. Sydney?
Yeah, the same. Can you imagine a country like ours, and even the city like where we are has been a very good impact. So I think maybe, as you said, is one positive experience that was developed. We were obliged to do because of the pandemic. That maybe we have more and more be very well established. We have been using telemedicine for the patients, even for coordinating trials. So it has. I think it's going to be used more and more in the future as well.
So there's considerable appetite among the clinical community to do this. Now, I wonder whether we could just have a little bit of industry perspective at this point. And one of you, if they've been reading the chat, knows that you're a plant for this. So Lionel, are you able to comment from an industry perspective on the discussion so far?
Hi, Mark. So I think I'm probably not the best person out of the industry colleagues who are on the chat to comment on that. I mean, I know that in general, industry, COVID-19 pandemic has affected all industry trials, whether adult or pediatric, but specifically pediatric ones. I don't know whether Heidrun or Catherine, I'm going to call you both out, may have more input to that.
Yeah, it's Heidrun speaking. Hello, my name is Heidrun Hildebrandt. I work for Bierer in pediatric development, and we have very similar what we heard from the academic colleagues. We have for most of our studies, we have stopped enrolling new patients, and we now, since maybe some weeks in Europe and other regions, we start the studies also with recruitment. But we had a handful of studies in oncology and one study in neonatology, which went on recruiting through the COVID pandemic. So we have not stopped recruiting, and that went on with a lot of activities going on a virtual route, and I think in one case even in having the manufacturing, the CMO directly delivering the study product to the patient. So there were a lot of effort in privacy rules, but it was at the end possible that the contract manufacturer could deliver study medication directly to patients. So that was one of the experience. And I think there will be a lot of learnings for industry at the end of the day after this pandemic, and maybe for regulators too, because obviously there were there were things stretched to a limit over this time in just getting studies going and getting patients the medications they need.
But I think we're hearing from everybody that there's considerable enthusiasm, considerable flexibility from the clinical and academic communities to do things differently, because we've always wanted to do it like this anyway. And we want to be flexible, we want to meet the patient's needs, we want to do things quickly. So hopefully we can all learn and improve our way of working, which I think takes us to Lisa's question. What are the barriers to accessing existing networks and infrastructures in other therapeutic areas, such as obstetrics, HIV and tuberculosis, for unexpected and acute problems like COVID, especially because the reasons for establishing those structures might remain important? So, Marianne, you were commenting on this. Perhaps you could lead off in the response.
Yeah, I think the barriers, there's not really barriers between the existing networks. It's really, in our context, the major issue was how to keep researchers, healthcare workers and staffs safe during COVID, because we all feared it tremendously when it started. But I think it's exactly what I was trying to say earlier. We've built a wonderful network in HIV/AIDS. We've built a wonderful network in pediatric tuberculosis. And those networks, I mean, it's all infectious diseases, can be used for these unexpected problems like COVID and learn together and be sharing on information. And from through the ethics review of adult trials, I gather that they actually are communicating and are working and are using existing networks. And I think this is actually on all levels. I found that instead of having barriers to accessing existing networks, we actually have improved our networking, and we are meeting far more regularly, whether it's now policymakers talking to each other, whether it's now ethics review chairs of ethics committees in South Africa talking to each other, or whether it's the infectious diseases groups. It's actually rather more improved, and that is also partly because we now use technology and we have these virtual meetings, and that really brings very quickly consensus in these groups of the way forward. So I think there's more advantages than barriers to because of COVID.
Great, thank you very much. I wonder if we could just turn to a couple of members of the team on the line for comments, and I wonder, Julia Challoner, Secretary General of CEOP, whether you could say something about this coming from the oncology perspective.
Good
Julia?
morning. Let me clarify. I'm Secretary-elect, so I don't take my seat until October. I just want to elbow my colleague Scott Howard, who is the current Secretary-elect. I was just typing in the chat, and I'll send it in a second when I verify that I haven't misspelled anything. The SIOP and the International Society of Pediatric Oncology and St. Jude Children's Research Hospital in the US have created a shared platform. They're trying to create a global registry for COVID, children with COVID and pediatric cancers. And I'm going to send you the link for that. It's free registration to get in. It is also hosting conversations about all the issues that people are mentioning on this chat. And I think too that because we are not seeing so many children as we had expected having COVID, being COVID positive, it has really made us think about how to react clinically, and also seeing not only the parents afraid to come to the hospital, but also staff being pulled from across the world from the pediatric oncology units to go to the ICU, say, or the emergency room. So already in places where I'm a nurse, nurses are stretched to care for too many patients. Now there are even more patients. And I think the comment that Dr. Kruger mentioned about children getting their meals in schools, I think there are also families that we care for with cancer in many low and middle income countries who are actually coming to the hospital because they know they're going to be, when their child is due for an appointment, because there's actually food at the hospital. So I think we're seeing things that we haven't seen in the past. We know that in one country in Africa, an NGO said that they were putting families in quarantine when they suspected they'd been exposed to COVID, and there's now a stigma when they are released from quarantine, which I think is another issue. I think this whole pandemic is raising questions and behaviors and occurrences that we haven't even imagined in the past. So I think we have much to learn, as everyone's mentioned, about what has happened in other pandemics. And the question is, we saw in the US a great deal of research that we now look back on that people did after SARS, and nobody took any action. So I think that at least within our government and some of the regulatory agencies, and I think that, do we learn this time that we must take action to prepare? And another question is the question of trust. At least in my country, people have lost a great deal of trust, I'm sorry to say, in the CDC and the government. And even if we got a vaccine, the question is, would people be willing to take it? I was on one webinar where somebody mentioned the anti-vaxxers are joining forces with the conspiracy theorists. So even if we got a vaccine, what would the uptake be like? And I think these conversations here that you're having on the chat are fantastic. And I appreciate the chance to at least learn from what everybody's experiencing. And I think it's something we're learning every day, how to make a better response. Thanks.
Thank you very much. I wonder whether we could defer. Oh, sorry.
No, just to say again that we were able to fight with everything because we are prepared before. Julia mentioned about distributing food and transportation. We have been doing that for the last 20 years for our families and patients. That's why we are almost prepared for, not prepared for the pandemic, but we have some that thing. Otherwise, again, I don't know what happened because you were not food. So we are distribute food and transportation. So basics always for that is mandatory for our communities, especially in Brazil, in countries like in middle income countries. It's essential.
Thank you very much. There's quite a lot more to say about vaccines. So I wonder if we could put that into the second bit in the T, because there's a couple of other perspectives that might be very interesting. And first of all, from India, I'd like to ask Nandini Kumar to comment on the perspective from India. Nandini? Nandini?
Yeah. Thanks for the invitation. What I would like to, all the issues that were discussed are actually happening in India as well. So the food supply, the medical supplies, all are a problem in India, especially in containment areas where people are not supposed to go, and one has to depend on the transport. But when there's a lockdown, there's no transport available. So, but there are actually institutions running clinical trials who have made efforts to get the local transport arranged somehow to bring the supplies to the patients wherever they are. But it's difficult, very difficult, because they have to encounter the police on the way. So if they have an e-pass for that purpose, only then they are actually allowed. So those are the difficulties encountered in India. Somehow the nation is trying to meet those demands.
Thank you very much. And also, I gather we have people on the line from Malaysia, and I think we're getting later and later into the night, so it'd be really good to hear from Jasmine from the National Ethics Committee of Malaysia. Any specific points of view from you, Jasmine? Thanks, Nandini. Jasmine, are you able to say something? Okay, if not, then I'll come back to Lisbeth's question earlier on about paediatric resources, and I wonder whether the Faculty of Pharmaceutical Medicine's resource is a good place to start. Ben, I wonder if you could just post a link to that resource. The FPM has some information, doesn't it? I think Sue Tandy and others have contributed to that from a paediatric perspective. So that might be one of the resources. But if Jasmine's not able to comment, then maybe we can come back to the vaccines discussion. And one other perspective we could have from Cameroon is Pierre Effa. And I wonder if Pierre, if you could say a few words about your view on childhood immunizations. Okay, Pierre, if not, then we can say.
May I come in there? I just want to say a brief word on it. I think one of the important, when we talk about vaccines, that we have a concern about, and that's perhaps for industry to reflect on, is BCG vaccine, which is now studied to see whether they can protect healthcare workers against COVID. Now, we in South Africa, as pediatricians, have been very concerned, and especially since we are a TB intensive research center, because we've had a major shortage of BCG vaccines, which was actually a global shortage between 2014 and 2017. And at the moment, we have a huge amount of children with tuberculosis, meningitis, with severe morbidity and mortality. And so, again, we want to argue the case that BCG should be kept for prevention of TB in high burden diseases. But we also know that the production is a little bit fragile because there's not that many companies producing it. And so coming back to children and their health, I think it's important for pharma to realize that we do need all those vaccines in adequate supply, especially if we're embarking on starting to research other areas for the same use for that particular vaccine. Thank you.
Thank you very much.
So let me just respond to that for a second, if it's okay. You know, it brings up an interesting point, which is for repurposed drugs that are nevertheless on formulary, we're seeing the indication for which it is not approved impacting the availability for those indications where it is necessary. We saw that, you know, in hydroxychloroquine and chloroquine, for instance, and folks with rheumatoid arthritis couldn't get it. And I think that we need to rethink that as we approach truly diseases that are outside the indication. We should figure out how to make that a part of clinical trials and clinical research, either by registry or by randomized clinical trials if we can, in order to learn early whether there is reason to believe in that purpose.
Great, thank you very much. So Ben's just posted a link to the Faculty of Pharmaceutical Medicine's COVID-19 blogs, which cover many of the topics that we've been talking about today from different perspectives. I think rather than opening a new question, we could perhaps pause the official part of the webinar now, and then we can carry on. There's a lot more to say, I know, about all these topics, particularly immunizations in the T space. So at this moment of pause, I'd like to thank the panelists for their insightful and experience-based contributions, which clearly bring to bear a lot of blood, sweat and tears from a range of clinical and research settings. So thank you very much to that. I'd like to thank the organizers, to Ben and Marcia and the team for setting up the call. And the next webinar is on July 29th at 4:00 p.m. UK time, and is about special populations in public health emergencies, part 2, rare diseases. And registrations are now open on the Faculty of Pharmaceutical Medicine's website. There's going to be a link in the chat box to complete an online feedback form and request or receive a certificate of attendance. So please do that now. And here's the feedback form just on the panel, the chat panel now. So thank you very much to the panel, to the organizers, and to all the people with the questions. I think we'll carry on discussions now, but thank you. End of part 1. Marcia?
Right, thank you. That's been a wonderful discussion. We call this part now the open house, and it's over to anybody who wants to come online and ask the panel a question and keep the discussion going. So I don't know if you want to perhaps pursue the vaccination questions, Mark. Does that need any further debate?
Well, there was a question from John Wise quoting Kenneth Frazier, CEO of Merck. If so, the people promising vaccines later this year could be hurting the overall fight against the pandemic. Any comments from the panel?
Well, I mean, I can say, I think at least in our local environment, the challenge of disinformation, poor information, overpromising is just been chilling. And it comes from, obviously, currently we are challenged with, sort of news that is sometimes trustworthy. So we've got a particular problem at the moment. But I agree, we should be very cautious about what we promise, because I think trust is important for us in the long term, and a core value that as scientists and clinicians we should uphold. So I agree. I think we should be careful, and I think we should be thoughtful in what we say, and I think we should be using the time to educate the public in general about the need for valid, scientifically rigorous evidence to support the work we do. So.
Yeah, Barbara, you're absolutely right. If you say that in the US, imagine what's going on in my country related to all informations and everything. I think most of you follow what our president did about chloroquine here and masks and so on. So information. So and then go beyond. So at least we have to be very careful what we are saying. But unfortunately, the politicians are not under control, and many other people here, and so that makes our lives here very uncomfortable, and very concerned about what could still happen.
Can I just ask, what can we do about these challenging people who have the media, who have the voice in the media, and particularly the anti-vaxxers, right? Because we want to educate the population, but when they're listening to these people, right, what is it you can do? Because we talk, I mean, it's really, what Barbara said is correct. We've got to have, trust is so important, and valid, scientific, rigorous evidence, right, to back that up. But when people don't believe the evidence, what can you do?
Marcia, can I suggest that we could save that bit for the beer garden after the tea garden, because there are a couple of questions that might take a little less time to answer.
No problem.
Maybe come back to that, but I can see, for example, that Graham Taylor has asked the clinical pediatricians for their views on how much of a risk children are to adults in terms of COVID transmission, and what evidence there is for that, for their views. Now, I think we need to ask all the clinical pediatricians on the line, because I know there are one or two. As a neonatologist who treats babies in incubators, then the babies are unlikely to be a source of infection. That's why I went into neonatology. Other clinical neonatologists, Marianne?
No, I'm a pediatric oncologist. But I have a lot of neonatologists in my department. And in actual fact, we've had a couple of neonates that got infected, and they got infected from healthcare workers. And so it's rather more that the neonates got the infection from them. And at the moment, as it looks, we don't think it's the children primarily infecting the adults. It rather looks the other way around. They go out in taxis and in public transport, come home, and then bring the infection into the home. So usually usually the parent is first ill, and then the child is tested, and then the child is positive.
So it's not like influenza where the children could be a reservoir of infection for the elders.
I would not
Sydney?
want to. I don't have a final answer, but it doesn't look like it. No.
I just say that may well be right, but at least in our experience, the contact tracing has not been sufficiently timely to know that. It's true that children are less impacted, symptomatic, but at least here the tests of positivity are taking anywhere from 2 days to now 7. And we don't know because we test for the virus. We are not testing for antibodies in the kids yet. So I think we've still got a lot to learn, but I respect your opinion, and I'd love to see the data for it.
No, I think you're quite right. It's too early to know.
Yeah.
There are too many questions about everything, so it's hard to answer a specific one part, because we also have to see about antibody, how the immune response, and then the vaccine, and so still a lot of questions to have a good, a broad view of the disease procedure in children. So it's hard to say something.
Yeah.
It's difficult.
If you think of where we are now, 6 months into or 7 months into this pandemic, how much we do know, and how seamlessly we've transitioned to a virtual world, it's just remarkable, the rate of scientific progress.
That's a good point. Maybe people, I have to keep that we started at least with a black smoke that was going through our nose, and nobody knows what to do. I say January, February, March. So, and now it's no longer as black smoke going on ours. We know something, but we don't know enough. But it's that's the feeling we had in the beginning, as a black smoke coming for every world. And then, so now I think it's not so black, but we need to learn a lot still.
Yeah.
Thank you very much. Any other clinical pediatricians on the call who'd like to contribute to that? Okay, if not, then maybe we could move on to a question from Ashok Swain from Mumbai. For a drug already approved in children for other indications and now being repurposed for COVID-19, should children also not be included in the COVID-19 trials? I think, Ashok, you mentioned that there are no studies like this in India at the moment. What is the situation in other countries? Are children being recruited to studies about repurposing medicines? Sydney?
Well, we don't have any study on that at this point. There are a lot of discussions about giving, and now it's, again, repurposed drugs like ivermectin had some discussions in the past, but not a study. But I do agree that children should be specific dose that we learn as a more impact the disease per se. The virus should be included in the trial, then we can learn, but see the population very carefully about that. I don't have more information from that.
Thank you. Marianne?
Yes, no, nothing at the moment going and nothing being planned either. It's only observational studies.
Yeah.
The only study is really one that is proposed for this new inflammatory syndrome that comes from the UK, which we basically all use, but it's not a formal clinical trial.
Okay, thank you. Barbara?
There are clinical trials in children. I would have to check as to whether they're the same clinical trials as are in the adult, or whether they're partitioned into separate trials. But that certainly, we saw them with hydroxychloroquine. Not that that is going to be hugely informative now, and we're seeing it in convalescent plasma. I don't think we've seen any studies in dexamethasone, and I'd have to look for the anti-inflammatories.
Yeah, I can just say that in the UK, there is one platform trial, multi-arm study called Recovery, which has been recruiting in pregnant women who are just as important, and in all children from 18 years down to 24-week newborn babies, and that's been recruiting for steroids and other medicines. So it's possible, but it does take some leadership from that group.
And I'll say that I think it's a really good good point, and it comes directly back to Mariana's first comments, that as soon as we know that it works in adults, people are going to use it in children, so we should be getting the data about children.
Great, thank you. Now, coming back to more vaccines, I think there's a really interesting question from Malcolm Brown.
For me.
For you, yeah. To test the efficacy of a vaccine, there needs to be high and increasing level of clinical infections. How does Sydney feel about UK-based vaccine developers carrying out trials in Brazil?
I don't feel UK at this point. How that word maybe in the past, UK was a little bit imperialist in that way, but I don't feel that. I really feel that collaboration is necessary, and I think the country has a big number, importantly, because of where we are in South America and all the political, economical issues. So I think we have to collaborate with that, and we have to collaborate especially in those high-risk populations to start. So I feel I'm pleased that this collaboration has been done.
I'm sure it's not just the UK, but maybe US or other high-income countries would be thinking in same terms as things spread. And the second part of the question,
together, I think we have to make what is necessary to run and to make those things going as quick as possible, and so this kind of collaboration is very important. We unfortunately have big numbers, like we have big numbers of other diseases, but what can we do? That's where we are and how we have to face and use again, access of that is a way to improve. So if you have access for the vaccine in the country sooner, that would be good for UK, for Brazilians, and for the entire community. I think it's important.
Thank you. So then I think everyone might want to comment on the second part of Malcolm's question. Who would get an effective vaccine first? Is that, Malcolm, is that people in Brazil or people in the UK? Is that what the question meant? We can't hear you, Malcolm.
Yeah, that's essentially the question. Yeah.
Well, I think we have to start with the high-risk population. If it's developed for that, I don't see the children as the first one. As so far, what we are seeing about that, but we see that the high-risk population, at least in this country, should be prioritized. Some words in English are difficult for not speaking.
But would that be the high-risk people in Brazil?
Yes.
Or in other countries? Because we've encountered at least one nation represented on this call that has bought up large supplies of medicines and bought up the rights to use large amounts of medicines and vaccines that have yet to be developed and use them only in their country. And if that country or other countries develop a medicine in a third country, who should get that effective medicine first? The people with the capital, the people who bought it, or the people who developed it?
Well, I must say our South African regulatory framework say that if you're going to come and test something and it's a sponsor from outside, it should be post-trial available, and there's a huge case for that. And of course, we know in a perfect world, it translates into that, and it doesn't always translate into having that access immediately, because there's all sorts of loopholes and barriers that you have to go through. But so the principle, I think, should be adhered to, that it should be at least available for the population that participated post-trial. And that, I think, comes from the ethical guidelines as well. It doesn't always practically translate into action.
Mm-hmm.
Thank you. Barbara?
So I think this is a huge issue that we don't have appropriate ethical framework for. I completely agree that there should be no testing on a population that will not have be entitled to access thereafter. You know, then you get into the questions of, does that mean the people that were tested upon, or the population at large, or intended to market in the country, all of which I think would be true. How we distribute a limited scarce vaccine over time. I think we don't have a model for that. I don't support what the US has done in terms of being the country represented on this call. I don't support what the position we've taken, but I don't know yet how to distribute it fairly. And I think that would be a very important question to think about, because certainly, you know, the Nagoya Protocol, for instance, which the US has not signed on to, again, doesn't speak to this event, doesn't speak to this issue of how do you distribute a scarce resource fairly.
Great, thank you very much. Great question, Malcolm. Now, there's one more question. In fact, there's two questions. Hello, Nandini, please.
I just wanted to say that India is actually having 2 vaccines prepared, which will be launched for clinical trials, and it is hoped that it will be used among Indians first.
Yeah.
Fair enough. There's lots of high-risk people in India. So we'll maybe ask, as time goes by, Susan Tansey, who works with the Faculty of Pharmaceutical Medicine and the Nuffield Bioethics Council, to comment on this. But while Susan's gathering her thoughts, we might come back to John Wise's question, which was, given the paucity of global and political leadership, the scientific community needs to step up to the plate. How might this be done? Now, that might lead into Marcia's question about how do we fight fact with non-fact, but maybe we could just start off with scientific leadership, and maybe each of the panelists, as a scientific leader, could comment on what the answer might be. Marianne?
Yeah, I think that is a very loaded question. We've had a very, and I'm going to give an example. We've had a quite bad experience because we've had extremely strict lockdown initially, and then it was changed from a lockdown 5 to a lockdown 4, as it's called here. And the ministerial task force has some of the very leading infectious diseases specialists in the country on that task force advising the minister. And it just so happened that we got regulations that were really absolute ridiculous. And I mean, one of them was that you couldn't buy T-shirts during lockdown 5, but you could buy home clothes because we're starting winter. So just to give you an example. Anyway, so she came out, a certain scientist came out in her own personal capacity and said she doesn't support this regulation because it doesn't impact on health at all, and so on. And there was a major reprimand that came from the politicians with threats against her and investigations. I must say what then happened is that the scientific community stood up and all came together and did write to the minister, and everything was retracted, but it was extremely unpleasant. So I must say, and again, we've just been meeting as heads of department of pediatrics in the country this afternoon prior to this meeting, because we are trying to assist the Minister of Primary Education to get children back to schools, because there's this trade unions and community that's very scared. And again, we are sort of taking the lead, but running the risk of being reprimanded by policymakers.
Right. Thank you very much. Sydney?
Well, it's maybe easy to answer. I don't know if easy, but here again, you know that even the scientific community said about, and we didn't have a health minister who is a doctor the last 2 months, because the president just fired him. And since then, I have a general from the army as the Minister of Health. So if we give a lot of statements in this, not only myself, but I mean the community, the people that can also make some actions don't hear, because that's not the political they want to hear. And the state of São Paulo is a little bit better, and the city of São Paulo is a little bit better, a little bit more organized. Then it has a more a discussion, and then things can they hear about what we have to say. But the country, what's going on in the country, as an example, we don't have a doctor or a health professional in leadership in the health minister. So
great. Thank you very much. Barbara?
I have no magic for this, except that I wish that science was better delineated from politics.
Yeah, unfortunately. And economy.
Yeah.
So I think maybe part of the answer also lies in people who lead networks, who lead infrastructures, that we can be learning this and getting the momentum for future work that people were talking about earlier on, as well as the and showing leadership within the community, as well as moving on to Marcia's question. So before we move on to Marcia's question, Sue Tansey is going to say a few words from her perspective with the Nuffield Council on Bioethics. Sue, maybe you could just introduce yourself. Hi, Sue, we can't hear you. Sue, we can't hear you. We did double check all this with chat, so Sue, can you hear us?
I can.
Sue? Marcia, could you unmute Susan?
Yeah, I'm just looking.
Hello, it's Will here. No, Susan is unmuted. I think there might be a problem with her microphone.
Oh, hello. Hello. Can you hear me now?
Yes, yes. Okay.
Yes, sorry, I know what it was. I wasn't using the same, I was using a big screen next to me rather than my laptop. You can hear me now, can you?
Yes.
Yeah, okay, apologies for that. Yes, I didn't realise I was going to be speaking, so I was using another screen. So yes, I wanted to just comment on the equitable access. As I was about to mention, sorry, I know I was on mute. I'm a fellow of the Faculty of Pharmaceutical Medicine, working as an independent consultant pharmaceutical physician, and I'm also a member of the Nuffield Council on Bioethics. After I've spoken, I can send a link on a paper that was recently done by the council, talking and discussing equitable access to medicines and vaccines for COVID-19. As discussed, I think it's very important that, you know, if clinical trials are being done in, sorry, and I just realised my camera's not showing me, that if we're to do studies in Brazil, India, you know, other countries, that the vaccines or treatments become available in those countries. As also mentioned, it's a, you know, it's complicated because it starts to involve politics and those kind of things, but I think it's particularly important. I also wanted to comment on the repurposing and the availability of medicines for rheumatoid arthritis and other conditions becoming less available when they're used for COVID-19, and I think that personally, I think that's a really important issue to address, to also make it clinical trials able to be run in the situation, because if people are using these medicines off-label, it also makes it more difficult to recruit people into clinical trials. So I think that's an important ethical issue. And also, just to mention, on the Nuffield Council website, we also have some resources related to doing the clinical research in developing countries that is also linked to this issue of access, because it's difficult sometimes to do research in those settings, but very important to do so. Yeah, I don't know, anything else you wanted me to comment on, Mark? Or
no, that's very helpful. Thank you very much.
Okay, so I'll send that link on the chat just now. Okay, thank you. Apologies for the problem with the the microphone.
Thank you. Now we may be able to link up with another global perspective from about as far east as we're going to get. Professor Leo de Castro from the Philippines. Are you able to comment on the situation in the Philippines?
Hi.
Yes, please.
Hello. Hi.
Hello. Yeah, we can hear you well.
Hi. Can you hear me?
Yes.
Yeah. What I can share with you is that in our country we've had a traumatic experience in the case of the dengue vaccine about 2 years ago. And the bad experience with the dengue vaccine has resulted in lower willingness on the part of the public to use vaccines also for other diseases. And we now have to worry about the possible acceptability of any vaccines that might be developed very soon. We are just hoping that because of the experience now with COVID-19, that the situation will have turned around.
Thank you very much. Other comments and questions? Okay, so I think we're coming to the end of our tea time, and maybe if there's no further comments or responses to what people have said, we can close this now. Marcia, anything else?
I just want to thank everybody for attending this excellent session. It's been informative, it's been engaging, and I've certainly learned a great deal. Mark, in particular, I want to thank how you brought in the world into this discussion. If I was able to play Lisa Stanfield's Been Around the World to play us out, I would. Right, it's been wonderful to hear the different views, the different perspectives, and the international perspectives. So that has been excellent.
I think, of course, we have a secret weapon when it comes to global collaboration, which is Francis Crawley.
Yes.
Who's been whispering in my ear about all the people, and I'm sorry if we've missed out any other perspectives.
Yeah.
But yeah, so yeah, I think Francis is in many ways a moving spirit behind global pediatric COVID collaboration and in other settings as well. So, and I think in many ways Francis has been behind this whole webinar series, hasn't he? And other groups too. So let's pay tribute to Francis and enjoy such collaborations in future. So thank you very much.
Thank you very much.
Yeah. Thank you everybody, and have a good evening.
Thank you. Thank you very much.
Thanks, Mark.
Thank you. Bye-bye.
Bye. Been great speaking with you all.